Well, first I'd like to thank the organizers for this wonderful opportunity. And as all the other faculty have mentioned, the hospitality has been extremely wonderful and we're really grateful for it. So today, just a small correction, I'll be talking about quality improvement for resource-rich and resource-poor settings. I'd like to start out with this quote. Everyone in healthcare really has two jobs when they come to work every day: to do their work and to improve it. I love this because I think this is a bottom line when it comes to why we pursue quality improvement. Just to go back to the baseline, what is the definition of quality improvement? It's an intentional attempt to change system of care in a methodical and systematic way. And Dr. Soul has already explained to us how we do that. So we just looked at this slide and we talked about it a little bit, but just to emphasize again, what kind of knowledge do you need to do good quality improvement? So first, you start with the generalizable scientific evidence, as we just discussed, from empirical studies. But in addition to that, you need to have good knowledge of the context, so the particular context you're working with, your unit's cultures, its belief systems, its history, and the unique characteristics. So why do we do quality improvement? The first reason is we always want to do the right thing, so to improve patient outcomes and to decrease waste and increase value. And it also gives us a competitive advantage. So when you look at centers, example, in the US, when we have ratings of our institutions, some of the factors such as your CLABSI rates and your unplanned extubation rates are taken into advantage. So if you are comparing and if you see the patient as a consumer, if this becomes transparent, then it gives you a competitive advantage that your center maintains a better quality of care for your patients. It's also to satisfy the regulators and the accreditation bodies such as JCO, CMS, and in India, I heard you have something called NHLB. And to avoid penalties, medical legal complications, media attention for safety errors that happen, and most importantly, angry patients and parents. We've all dealt with them and it's not a good thing. I'd like to show this graph just to highlight the fact that there has been a tremendous increase in survival. So here you're looking at babies, premature infants that was born in India between 1995 and 2003. And as you can see, for every category of birth weight, there's been an improvement in survival rate. So it makes it even more important that we focus on improving the kind of care we provide for these babies in our NICUs. So how do you do quality improvement? Seems pretty simple. Dr. Soul just kind of explained this as well. You identify a problem, you understand the extent of it, you identify the root causes, what is causing the problem, you determine the interventions or changes, you make those changes, and you measure outcomes and learn from it. So this is analogous to how we take care of a patient. When a newborn is admitted to our unit, we get a history. We look at the perinatal history. We look at mom's pregnancy-related complications, the delivery room resuscitation, and then we examine the baby. So we're collecting information. And then we come up with a working diagnosis. Then we might order some labs and prescribe a treatment. And we watch the baby, and as the clinical course evolves, we change our plan. So this is, doing quality improvement is just like that. Instead of the patient, you're just looking at a problem. So there's a lot of models and schemes for how you would go about doing a quality improvement project, but this is a popular one and one I think most people are familiar with, the model for improvement. So it addresses three important questions. What are we trying to accomplish here? How will we know that a change is an improvement? And what change can we make that will result in improvement? And then you're all familiar with the PDA cycles that we do to track the improvement. In terms of prioritizing your improvement goals, I won't go into too much detail since our next speaker will talk about it. But I think some of the factors to take into consideration are seriousness of the quality problem. If it's something that's resulting in mortality or a severe adverse event or a serious complication for a patient, obviously that takes high priority. the frequency of a problem. How often is it happening in your unit? If it's something that happens, every 3 years, maybe that's not your priority. Ease of implementation, the need for it, likelihood of success, and cost are other important variables you want to take into account. So this is kind of how we deal with choosing QI projects in our unit. We keep an active list of things that are broken or things that need to be fixed. So it's equivalent to an active problem list for a patient. These are what we refer to as opportunities for change. Then we look at our quality indicators, such as our CLABSI rate, our unplanned extubation rate, our rate of hand hygiene, our compliance with oxygen saturation targets, you name it. So those are like the vital signs of a patient. And combining these two lists, we come with a priority list, and we take into consideration the resources at hand, the probability of change, the emotional appeal of these issues, and the practicality. After that, we select one single quality initiative, we develop a specific aim for it, and then we do sequential PDA cycles to complete the project. So this is an example of a specific aim. The reason I put this up here is I think far too often when somebody starts a QI project, it's easy to just have a general aim and say, I want to improve infection. But I think it's important to be very specific and to set some boundaries in terms of what are you trying to change, what kind of effect size are you trying to see, and what is the timeline for this. Without this, I think it's easy for quality improvement teams to not adhere to a schedule. So preparing for an improvement project, how do you get started? You create a multidisciplinary team. It's crucial that you allocate time and resources for this team. So if they have other clinical obligations, it's good to give them a designated set time that they can devote to this. You need support from data and informatics to do this well. And you want to create a project charter, which is a written plan of proposed project and timeline. Here, I'll give you an example. In our unit, after looking at our Vermont-Oxford network data, we realized that we had an issue with chronic lung disease. We consistently had rates that were higher than centers that were comparable to us. There was also a subjective impression that some of our respiratory care practices were leading to lung injury. So I created a team, a multidisciplinary team called Team ALLY. We all like abbreviations. So it stands for Avoiding Lung Injury Team. And it's been a huge hit. It includes respiratory therapists, physicians, nurses, our quality improvement specialists, data specialists, and evidence-based medicine specialists. So we get together and we look at our respiratory practices from the delivery room resuscitation to CPAP care to extubation, intubation criteria, and modes of ventilation, etc. So we take one project at a time, not to overwhelm the team, and go through it systematically until we resolve it. So our first one was one that we talked about at the workshops, which is what type of interface is good when you're delivering positive pressure through CPAP. Is it prongs or is it mask? So that's an example of how a team can be assembled that has a theme. This team looks at all the respiratory issues in our unit. And then we go through the process of reviewing the evidence, the first step of knowing what we should be doing, either from policies such as from American Academy of Pediatrics, if it's relevant, or it's from the evidence, or from synthesis of evidence such as from EBNEO. And then we decide what project we're going to select and go from there. So here I want to give you two examples of quality improvement projects. The first one is from my home unit, and the second one was done here in India. And I think as I go through these projects, you'll notice a lot of commonalities. So this first project is regarding unplanned extubations in a large NICU setting. So our unit has a capacity of about 173 beds. And we are dealing with staff that range from about 480 nurses, 50 nurse practitioners, 50 respiratory therapists, and a large group of physicians as well. So the definition of unplanned extubation is dislodgement of an endotracheal tube from the trachea that is not intentional. It's common and it's a preventable adverse event in the NICU. Even though it seems benign, it has important patient safety concerns that have been well reported, such as cardiorespiratory compromise, airway trauma, and really any other complication related to reintubation. The reported rates have ranged from 0.14 to 6.6 per 100 ventilator days. So the overall aim for this team, and I wasn't involved in this, but the team has decided that their aim was to identify factors contributing to unplanned extubation and develop targeted interventions to reduce the rate of UE by 20% from February 2016 to September 2016. So just to give you a timeline and history of this project, in 2013, somebody in our unit just started collecting data on UEs. And in 2014, a year later, a multidisciplinary team was created that included all the specialists mentioned here. And a database was created to collect pertinent data in real time. While all that was happening, there wasn't really any structured quality improvement work going on. But in 2016, there was a renewed interest, and this time they were serious. So there was another group that formed that used the RCA methodology to review each UE event. It's actually really impressive to witness one of the meetings for this group. They take every event so seriously and they go through so much detail to figure out why it happened. So they review the safety event reporting system, they interview the bedside nurse, they talk to the charge nurses who write reports, and they've created a bedside debrief form to help them collect information. What they've noticed when they collected it is that there are recurring themes. So these are some of the categories that the team identified. The unplanned extubations were happening either because of improper or inadequate ET tube position or related to patient being too agitated, securement issues such as do you use a tape, do you use a neobar or another kind of device, and there's some high-risk periods such as when you're moving the baby, transferring them, weighing them, or doing a procedure. So this is just a breakdown of those categories, and you can see here the various categories and the incidence of it in our unit. So they launched a series of interventions, and the first is that they wanted to make sure that a patient was really extubated when you declare them to have an unplanned extubation. Many times what we noticed was the nurse would call the physician and say the baby's extubated, so I pulled out the tube. So there was no process to actually make sure unless there happens to be a bedside on RT right next to the bed. So they created another acronym called PACE to help staff remember how to assess for this. So each nurse, when they encounter this situation, assesses for the position of the ET tube, auscultates for breath sounds, looks for chest excursion, and looks for end-tidal CO2 detection. And their second intervention is called Where is my ET tube? This was because they were noticing that many times the ET tube wasn't in the proper position. So to improve staff awareness for the ET tube depth and make it a routine practice to confirm placement, they made it so that every shift a nurse checks and calculates this. So just for people to remember easily, they developed this acronym. WAIT helps ensure right ET tube depth. As you can see, our team loves acronyms. Intervention number 3 is they wanted to address these high-risk periods when babies were moving around. So their intervention was to have 2 providers at the bedside, and one of them was strictly in charge of ensuring that the tube stays in place while the baby is being moved. So in terms of how they implemented all these interventions, it required an extensive amount of staff education, especially considering our large group of nurses. They used unit newsletters, they put flyers in the break rooms, emails, all the typical things that you would do. But they also made it mandatory for their clinical competency training so that the nurses couldn't really opt out of it. And another unique thing they did was rolling sims, where during a particular shift, the charge nurse would go bedside to bedside, and the nurse can practice how she would secure the ET tube if she were to be moving the patient. So these are the UE rates, the results. So as you can see, I don't know if you can see this well, but in the beginning, it starts with October 2013 and it ends with September 2016. So the initial phases in 2014 and 15 is when the team was formed, but there was no interventions and no rigorous data evaluation. But as you can see, by the time that the intervention 1, 2, and 3 were implemented, we seem to be below the mean. So our overall results from the team are that there was a 41% decrease in the UE rate from 2015 to 2016. It seems well sustained. Our current rate as of today for 2017 is 1.03 per 100 vent days. And I would say in our unit, when we look at our quality improvement work, everybody knows about this project and they're really proud of it. And it's one of the rare projects that's sustained really well. The other thing the team looked at, because they have access to so much data, is to figure out if there were some patterns. They wanted to see what time of the day these events were occurring. And as you can see, they're really spread out, hard to tell, but perhaps there were a couple of time periods that correlate with nurse breaks and shift change that seem to have higher incidence of these events. They also looked at the day of the week, and maybe there is a subtle increase in the weekends or nearing the weekends. One of the things that they noticed from interviewing staff is that often they realize teams make plans on rounds, and they'll say, this baby is ready for extubation, let's do it after rounds, or let's do it after lunch, let's do it in the afternoon after my meeting, or I don't want the weekend team to deal with it, let's leave him intubated, and on Monday we'll extubate him. So their next campaign is called Don't Wait, Extubate. They want babies to be extubated as soon as the decision is made, implying that as soon as they meet the criteria and not at a scheduled time. So our team used sequential PDA cycles, which helped us develop knowledge over time and led to significant improvement for our babies. So the lessons learned here are that educating a large number of staff is challenging and requires a lot of creative ideas. And you need a dedicated work group, not just random people assigned to it. And it's important to celebrate victories. I think it brings a lot of notice to the project and it helps with sustainability. And it's crucial to look at unit-specific data and create interventions that target the unique complexities of the local settings. Those categories that I described might not apply to another unit. So it's important to look at your own unit and your practices to see where you need to intervene. So the second project is from India, and it's called Infection Control QI Initiative, and it's by the investigators, Dr. Rao and Dr. Chakravarti. So this is a single center experience with a very comprehensive QI initiative that was done between June 2015 to August 2016 in a neonatal intensive care at St. John's Medical College in Bangalore, which has 2,500 deliveries per year. Their aim was to decrease the incidence of healthcare-associated culture-positive sepsis rates in neonates admitted to the NICU by implementing and maintaining certain quality improvement measures in key identified infection control areas. So they divided their project into 2 time periods, a baseline period, which lasted 3 months, where they collected data and started setting up mechanisms for collecting baseline information regarding their infections before they started with the interventions. And then they also had launched serial interventions over a 12-month period in different phases. So it was a pretty extensive sequence of interventions. It involved hand hygiene, not just looking or aiming for compliance, but really emphasizing the technique. So they did a lot of teaching for their bedside providers, for their physicians on doing a proper hand washing. They also did a lot of central line bundle care that involved an insertion bundle, maintenance bundle, checklists, and daily reminders regarding line removal and continued assessment of whether you need it. And in addition, they had a ventilator-associated pneumonia prevention bundle, surveillance and cohorting of patients with multi-drug resistant bacteria. So it seems like a pretty extensive project, but these investigators invested a lot of time and were very insightful and thoughtful in the way they carried the project through. So they used a number of PDA cycles. They really reflected on what they were doing right and what they weren't, and took a lot of opportunity to retrain staff. And here are their results, which are very impressive. So if you look at the culture-proven infection, CLABSI rates, and the ventilator-associated pneumonia rates for the 1,000 ET tube days, you can see a significant decline in them from the baseline period when they were just collecting data to phase 3, which was at the end of their intervention period. Consequently, their antibiotic utilization rates also dropped during the study period, which is critical in considering the nature of antibiotic resistance in India. So their results included that the hand hygiene improved from 0% at baseline to about 45%. CLABSI rates decreased by 89%. Line days improved. VAP improved by 77%. And the MDRO, or the multi-drug resistant sepsis, decreased from 40 to 16%. And this is very impressive, their rates of CLABSI and the bloodstream infections. And as you can see here, there are several months where they had 0 infections. So this will look like the exact same slide that I displayed before when I was referring to the project from my home unit, but these were the actual lessons that the authors report learning, which is to choose a multidisciplinary dedicated team, appreciate teams' accomplishments, and have accurate data collection systems, which can be challenging, and do recursive training of staff, and to encourage sustainability. So essentially, my big take-home message is that QI is universally applicable. QI initiatives can result in numerous and significant benefits for any given NICU setting. And a successful QI project requires multidisciplinary team and involvement by various stakeholders, a methodical approach, choosing interventions appropriate for the setting, a lot of patience, a lot of training and retraining, and efforts at maintaining enthusiasm. And this particular article I wanted to bring attention to by Dr. Chawla and Dr. Suresh, because they have a nice plan for any NICUs in India that either want to do their QI initiatives or form a QI collaborative. Just some suggestions on how you would go about starting. And finally, I would like to thank my mentor, Dr. Gautam Suresh, that many of you may be familiar with, and our NICU staff and patient families for participating in the QI projects that I mentioned here. And these are some pictures of our unit. Thank you.
That was an excellent talk. And if some of the key elements of patient care are lacking, like nurse-patient ratio. So we have here in public hospital 500 beds and 100 nurses. We don't have 24/7 water supply. So if those key elements are missing, and yesterday we listened to in one of the orations that water is contaminated. So you start doing hand hygiene and other things, but your water is contaminated. If the key elements are missing, what will be the role of QI then?
Yeah, I mean, that's an excellent question. And I think that's the reason that many people get discouraged. But I think that's why it goes back to the point of having the knowledge of the context and your setting. So a lot of people in the US use the Scrub the Hub project. But if you don't have a hub to scrub, that doesn't really apply to you. So you have to really look at your unit and see where you can make it. I don't think you can necessarily take another QI project and replicate it. Even in this unit in Bangalore, I would say they had a lot of resources to be able to do this, maybe not as much as us, but they were able to improvise and really think about novel ways to work around it. So I think in your case, what you're describing, you just need a lot more time spent in identifying the problem and clearly defining it before you just jump ahead and say, sure, hand hygiene, that's a solution. But for you, maybe it's not the hand hygiene, but maybe it's the 5 steps that come before it. So I think it's just the interventions have to be very specific.
So I think what Srinivas is saying, I think all neonatologist champions in each and every unit and state need to make sure that we have quality assurance standards in the unit in the small district hospital. Don't talk about no water supply, no electricity, no nurses, no manpower. Then what you are doing? It is not running an ICU then there or a special care nursery unit. So you need to get to the bureaucracy, leadership, the politician who is in charge in the state, convince them, sit them across the table, make sure unless they put those things in place, quality of care for babies and mothers is not going to improve. Babies are going to die, mothers are going to die. Please make QA standard, which Government of India has written as NAQS standards of 2013 and 16, which are published by central government. Get them implemented by your state government, sitting through the leadership and making that change happen. And then only your healthcare providers will be motivated to do quality improvement work. This can't be done as solo for improving care for the patients.
I'm Saurabh Datta from PGI Chandigarh. One of the favorite quotes of your mentor, Dr. Gautam Suresh, is that make the right thing to do the easiest thing to do. And if one can do that, then quality improvement initiatives meet with success. Sometimes what happens is that in the process of quality improvement, the right thing to do is made so complex that compliance falls. So you are able to maintain it in a study mode, but once the study finishes, then things again slip back to what they were earlier. So what is your take on this? Of how strategies to make the wrong thing actually the more difficult thing to do and make the right thing to do the easiest thing to do?
Yeah, excellent point, and I agree with it completely. I think if you come up with an intervention, as you mentioned, that's so complex and deviates so much from your routine care practices or your just workflow, it's highly likely to be unsuccessful. So I think depending on the nature of the intervention, you have to come up with really clever ideas. For example, in our UE project, at the initiation, everyone thought it was impossible. We're such a large unit. We have so many nurses. We have nurses that float from different units like the PICU or CVICU. They won't remember what to do when they're here. So we just have to work around it. One of the examples I mentioned was these rolling sims. So when you schedule nurses for a simulation session, that means that they would have to come on their own time, find a day off, and come in and do it. But if you made it part of their work day, they're already working and you're the one who's making an effort. That's an example of how you can make it easier. But I think we just have to be really clever in coming up with ideas. And I absolutely agree and can't emphasize enough that if you leave the burden of these changes to the frontline providers who might already have a lot on their plate, then it's not going to be successful. And that's why you need a team that has the devoted time and resources. Just little things, clever ideas. In my fellowship, we had a campaign against infections that was very, very active. And they just took every opportunity to emphasize this. So from little things like screensavers to giving crossword puzzles and just taking advantage of the time that the nurses are in the NICU. So while I don't have a specific answer, I think each project needs its own clever ideas.
Thank you.